Today we're going to be talking about plantar fascia pain, and a lot of people have probably heard plantar fasciitis is a term. And so we're going to talk through what that is, what it's not, and then some quick tips on treatment and how shoes play a role if they do. And so we're going to get into all that stuff. And today Matt is kind of our tour guide through this. And so I'll be pitching questions to him, and David and I will be adding to it as we go. But Matt, why don't you start by giving us just a general kind of definition of what plantar fascia is and kind of the anatomy.
Yeah, sure. So the plantar fascia is a very important structure on the bottom of the foot. What it does, it's a band of fascia, right? But it's this very thick tissue on the bottom of the foot that gives an additional amount of passive rigidity and structure to the foot, because the foot has a lot of mobility. There's a ton of joints there, and the foot needs to be mobile but also stable at different parts, either during the gait cycle or a variety of functions. So this thing starts way back at the heel, and not like necessarily where the Achilles comes down, but a little more forward, kind of deep in the heel a little bit, and then it spreads out farther and goes forward and ends up spreading out into the toes. While it does that, it attaches to various points along the bones that move across there. But one of its main functions, besides providing a little extra structure, is how it does that is when you extend your first toe, or any of the toes for that matter, but especially the big toe, it actually tightens this thing up. And so why that's important is when you are toeing off and you are going into what's called terminal stance and pushing off, you have to, or you're supposed to be able to extend that big toe. And when you're pushing off your foot, you want your foot to be locked up and stable. You don't want to be pushing off an unstable surface. So the plantar fascia is part of what's called the windlass mechanism, where it helps as you roll over your first toe, it locks up the foot as you start to go and supinate, or at least you're supposed to, so that you can push off a stable platform. There's some discussion that the plantar fascia can be considered a structure that helps with force transmission from the calves into the toes as you push off, but it's a passive structure that has a lot of active influences into it. It's very important. You do not want to lose it. There are some very interesting things that happen when you have a plantar fascia release. I would not suggest that unless it's an end thing, and we're not going to totally talk about that, but it's
just really,
also
really quick. When you talk about, we're not going to go into it, but just when you said plantar fascia release, that means taking it and cutting the plantar fascia.
Yeah, I would not suggest that unless there's like really nothing left, because it's a very important structure. So people often ask like, oh, can I cut it out? I'm like, you don't want to. It's very important for providing stability and a little additional structure to your foot. So
and when you said that it's a fascia, thinking of that like a ligament kind of tissue, where almost, it's nothing contracts. It's just like thick and it
fibrous tissue,
rigid. It's like if you were to pull on it, doesn't stretch. It's just kind of like a rigid tissue.
Yes.
Some stretch, but not a lot.
Right. It's not a muscle. It doesn't contract by itself. It reacts to positions of joints, essentially.
The other thing I felt like I heard you say too, just from how it functions, is that it's going through a lot of changing in position as we walk. It doesn't just sit there kind of like our MCL, which just kind of like sits there for a lot of times if we're not putting stress on it. This one, every time we step, it gets stretched and then it gets relaxed and then stretched and relaxed. And so it's going through a lot of motion.
Even though we call it a passive structure, meaning it's not activating on its own, it goes through a lot. That we put a lot of pressure through it, which is why you got to take care of it.
So most people have heard the term plantar fasciitis. Can you go into why it's been called that, and just maybe some insight into why we don't necessarily call it that anymore?
Yeah. So a lot of things, tendonitis, fasciitis. Itis usually refers to acute or very short-term inflammation. Okay, so usually when you have when I say acute, I mean injury that just happened like a couple minutes ago or a couple days ago. During that phase of healing, right, you've just injured something, there is usually inflammation that happens. Your body's trying to go, all right, I got to get whatever damaged tissue out of there and get some new stuff in here and start rebuilding. The problem with that is that a lot of times these structures aren't always in the acute early phase, right? Oftentimes you can injure them and not necessarily have pain. And so this can actually be going on for a very, very long time. And when pain starts to show up, it may not be acute. It may be what's called chronic, where it's been going on for so long, there isn't any inflammation anymore. So depending on how long an injury has been going on changes what's happening physiologically, and also changes how you treat them. For example, you can put ice on an inflamed joint or inflamed tissue, because that should theoretically, that's a whole nother conversation, should theoretically reduce some of the inflammation response. But there's really no point to put ice on a chronically injured tissue, because there's usually not inflammation. You can have pain, but no inflammation. So that's why we've really stopped calling it that, or at least we should stop calling that, because you have to really identify what phase of healing it's in, which can also be hard, if not impossible, depending on how well the patient's able to tell you, this has been going on a couple days, couple months. It can be very difficult to figure out how long things have actually been going on, especially a lot of the individuals that are diagnosing them oftentimes don't have the time to take the history necessary to figure that out. So we oftentimes recommend not calling it fasciitis, because it's often not acute. It's often been going on a lot longer.
And like you said with that, I think the big crux is that it changes how you're treating,
right?
Because like Matt was kind of saying, just to reiterate it again, I think if you do something, if you lift 300 pounds with your biceps and your biceps lets go and tears, it's going to swell, or hamstring, whatever muscle, it's going to blow up. You're going to get the bruising, you're going to get swelling in the area, all of that stuff. And that's a piece of the inflammation. Right. And then the question is, okay, how do we treat inflammation first?
Right.
But if inflammation is not part of your pain or your situation, then you don't want to treat inflammation, and you want to treat it a different way.
Right.
And so we'll have to get into that later.
Right. We'll wait for that. Okay.
Yes. Yeah.
I'm learning.
Let's talk next a little bit about predisposing. Well, actually before that, let's talk about going a little bit deeper into what are some cues that might tell you whether if it's acute, like a true like itis, or if it's something a little bit more chronic, and where is it and how well can we do that?
That's a very good question. David, did you want to jump in a little bit?
Sure. I mean, between acute and chronic, you can take a look at the history, and if there is a mechanism of injury. I think that's a very important thing to acknowledge, because let's say, I'm just trying to think of something off the top of my head. Like if you have a very, very heavy load, like you're moving a bin or something, and you have to push off of your foot there, and you get an immediate intense pain. Usually this is more of an Achilles or gastroc type injury, but let's say it's to the bottom of the foot.
I got one. Dante DiVincenzo in the playoff game against the Heat, he planted and to cut, and he tore his plantar fascia. Perfect. So he stepped and cut and had this immediate sharp pain on the bottom of his foot. Yeah, so there's an acute mechanism of injury. There's something that you can say, this did that. And that helps you as a clinician determine how you're going to treat something. I think it's important to get that history as well, because a lot of physicians will say, hey, you have foot pain right there. Okay, go see PT, plantar fasciitis. So a lot of times screening is important. Sorry, I didn't mean to keep going. You can go ahead, Matt.
No, that's fine. So acute stuff, usually there's a very specific incident that caused the symptoms, right? So getting that from the history is really important. It's always important to make sure you understand where the patient's coming from. Chronic can be, hey, I've had this thing on and off for, a couple months or a couple years, and then all of a sudden it really flared up. If there's been on and off symptoms for a while, that's going to be more chronic. Even if there's not like a specific one time that it started, you're like, oh, back. If there's been some symptoms on and off, that there's probably some mild injury occurring. And like I said, just because you have an injury doesn't mean you're going to have a lot of pain. And I'm not trying to scare people. I'm just saying that's how we figure out whether this is acute, i.e. very short term, it just happened, there's a big injury, or if it's been going on and on, you've got some kind of ongoing, I don't know what the right term to use is without creating any kind of fear here. But just some like mild tissue irritation that's been going on for a while.
Irritation, that's the word I was thinking. Yeah.
Again, they respond very differently, because one of them, typically, you've got a big thing. We treat that very differently. The tissue is very different from when it's been just happened versus it's been going on for a while. Your body's trying to heal it, and it may not be healing as much as necessary.
And it's also possible in these scenarios where you've had this thing that's come periodically over and over, and then you do have a big incident. But in that case, you've got both, where you have to treat the acute scenario and you have to treat the ongoing scenario.
And that's called an acute on chronic injury.
Yeah. So we got a lot going on there. And I think one of the other pieces is it's hard clinically or by yourself as a runner to be able to differentiate between the two. And so a lot of times the way that treatment ends up looking is trying to address a little bit of both, unless it's pretty obvious, but it's murky. We
Right.
don't have the ability to go in and although some things are improving, but we don't have the ability to go in there and grab the inflammatory markers and say, yep, they're present, or no, they're not.
Right.
And the juice of that is not worth the squeeze. So to be able to go to order that kind of testing for pain on the bottom of your foot near the heel, kind of underneath there, isn't necessarily worth it. And,
it's not worth it, because oftentimes it's actually normal to have some of those just in general. And so we've discovered that, like, a lot of imaging, unless you're absolutely like certain you want to double confirm it, it's not worth doing, because you can have some of the signs in imaging without having symptoms or any pain, even so it's like Nathan said, not always worth the squeeze. I'm going to add something really quickly, I promise. The other thing that's really hard with plantar fasciitis, and David made a good point, is oftentimes people go, oh, pain on the bottom of the foot, plantar fasciitis. You have a lot of other structures there that can also get irritated. You have a lot of muscles in that area. You have a lot of other ligaments in that area. And so if this is not assessed by a professional and you don't get a correct diagnosis, you might be treating it totally the wrong way. And I see a lot of people who say, oh, I have plantar fasciitis. I'm doing all the classic things and it's not working. And it takes me 30 seconds to look at it and go, this is not plantar fasciitis. It's not even in the right area. So there's a lot of stuff there. So do not always assume, oh, I have foot pain, it must be plantar fasciitis. There's a lot of other factors.
I think the other big differential outside of the foot itself is nerve pain. And so there's parts of the tibial nerve branch to the bottom of, it doesn't really matter. There's branches of nerves that go there that can either be impinged down at the ankle, even up at the knee, or up in the back. So all the way up to your spine, there are things that can be leading to pain that feels pretty much exactly like plantar fascia pain. And that's when, if you try some of the, and we're going to talk about some of these things to try, but if you've tried all of these things on your own and it's not getting better, that's where seeing somebody who can screen kind of for these outlying scenarios of foot pain can be helpful. And we'll go there.
Right.
But let's talk next kind of about what are some known predisposing factors for people who have plantar fascia pain, meaning they looked at a bunch of people who had plantar fascia pain and they were like, what do these people have in common? Like, what are some things that may have been leading to the plantar fascia pain? What are some of those things? And I've got a couple, but I'll let you guys go too.
So one of the big ones is obviously having a large body mass. Okay. So the heavier you are, and not necessarily if you're muscular, but if the heavier you are, the more weight you're carrying, the more impact that goes through that tissue, and the more that tissue has to handle as you progress over it. So large body weight is certainly one of them. Longer, correct me if I'm wrong, like work-related stuff where you got to stand on your feet for long periods of time, not just running. And so we don't just talk, we also, when we're talking about this stuff, recognize that sometimes running may not be the thing that injured it. It may be other factors that in an individual's life that may have caused this. Correct me if I'm wrong, diabetes is also a really, really big risk factor, just because, especially when that gets more advanced, it starts changing some of your physiology, can very negatively affect some of the tissue, especially out in your extremities, like your foot. Nathan, you had a couple other ones. David?
Yeah. I mean, I think it kind of goes without saying to some degree, but just repetitive motions that could potentially irritate it, and in a chronic nature, especially if there's already some discomfort or inability or lack of motion in certain areas, and maybe you're putting excessive stress on it chronically. But I would just say repetitive load and stress.
Yeah. Especially specifically overtraining or training more than your body is capable of handling, and it can't heal fast enough.
Mm-hmm. A couple other of the regulars, they found that people who have decreased length of their calves, so tight calves where you have decreased dorsiflexion, meaning your ability of your toes to come up, that's a predisposing factor, which makes sense from Matt was talking about how some people argue that the Achilles comes down into the heel and then it wraps underneath and attaches right into this plantar fascia. So that, you know, they work together as a unit to create these the propulsion off of the toe. And so if you have tightness in the calf, the idea is that that creates a constant tension through the plantar fascia, which could be predisposing to some of that. So that's one thing. And then another one that I've read about, there's a study that was done just looking at for these, and it talked about decreased hamstring length as well. So people who have tight hamstrings, which I haven't fully figured this one out, but people with tight hamstrings.
It could be a fascial relationship. Yeah, down the posterior chain pulling up on the proximal gastroc, which in turn pulls on.
Yep.
I could easily see that being a relationship.
So
nothing works in isolation.
Yeah. Check above and below.
Yep. And these we should state too, like most of these studies are done in a notion where we can call them correlations and not causes, but it doesn't mean that you shouldn't think about making sure you have adequate hamstring length, and meaning that they're not tight and that your calves are also stretched out as well.
But I should note the things that we are talking about are coming from evidence-based practice, right? So we're referring to the physical therapy clinical practice guidelines for plantar heel pain. And I'm also referring to a couple other systematic reviews that are out there that have also supported what we're talking about. The hamstring one, I think I know which one Nathan's talking about. There's still early evidence. It's not really in a full-blown thing yet. We still need to confirm that, definitely correlational, but there's a lot of research on this stuff.
So here's the question, kind of starting to veer into the treatment side of things. And so I think we can kind of put together prevention, and if you start to just get these first niggles of, oh, I'm getting a little pain on the bottom of my foot, what kind of stuff do you recommend that people try to do?
I'll let David start, because I think this is something we're super fortunate to do, is having this knowledge means that when something shows up, we're able to usually go, I know what this is. I'm going to knock it out of the park really quickly. So that's the awesome part about being a physical therapist or any rehab professional, being able to recognize it and knock it out of the park. And he was able to do this. And this is probably one of the reasons you came back as fast as you did, probably not as fast as you want, from the ankle sprain. So David, why don't you start on what you would say early on? If you started feeling some symptoms like this, what would you do?
Probably take a deep breath first.
There's some big evidence on that, especially as related to stress and fear affecting pain. So that's not a joke. That's actually very serious.
Yeah. Take a deep breath, take a look at things. It's obviously, it can be difficult to find what the pain generating source is. I mean, obviously you have a location, but that doesn't exactly mean that's what the problem is or where it's coming from or why it's happening. I'd probably start off, I know my ankles can be a little on the stiff side. I know my calves are a little bit on the tighter side. I probably would start with a little bit of ankle mobility and some calf stretching. I don't know if I would go straight to great toe extension. I know a lot of people have a habit of doing that, especially in the Instagram media world. People love to show those little like rollers where you put your great toe on it and then you lean forward on it and really lengthen that thing out. That just looks irritating to me, especially early on, unless you can really dial it in that like this windlass mechanism isn't working. You can go ahead, Matt.
What David's talking about is any time that you start to feel things, don't be aggressive with it. Because if you do have even a mild acute injury, if you're super aggressive, you can make it worse. So like, especially working on like gentle stretching of the calf. I don't know if I would do stretching of the first toe, just because that's going to directly pull on that tissue versus like stretching the calf. At least there's going to be some tension, but not nearly as much of that. So gentle. The other thing I would add is like maybe doing a little bit, like get a tennis ball, not a golf ball initially, but like a tennis ball, gently rolling out the bottom of your foot, right? Don't kill it, right? But gently rolling that thing out, maybe rolling it on an ice, a frozen water bottle is also a really, really common thing. Well, that's going to be a common recommendation that people make in general. And just continue to try to move appropriately within a pain level that's tolerable to you, and maybe modify some activities as needed, but don't stop moving if possible.
I think it's important to note that this is a fascial structure as well. And for the listeners and the viewers out there, fascia isn't necessarily the structure that's purely linear. It is multi-directional. You can almost think of it as like a giant, almost like little spiderweb matrix that lines all of your tissues and ligaments and tendons, and you can get all whacked out with it. But
I'm very sad that people could not see that on people listening to podcasts.
If you're listening to this on audio, we're wigging out.
You did not see all the arm motions from both Nathan and DJ. So maybe we will turn this into, we'll grab that for Instagram and post just that little section. We'll talk to Bach.
Yeah, but that's probably, for me personally, I probably would start more at the calves and a little bit of ankle mobility, because you can affect the structure from above while putting a lot less force on that area. And because this is a fascial connection, you can actually ease some of that tension without addressing it specifically. Like you could not touch it at all and still affect it positively. That is something that I think a lot of people aren't really aware of. That they think it hurts here, so I have to address right here. But you don't have to go straight to the point immediately, at least.
You can definitely loosen stuff up around it, and that can commonly be a nice way to unload it. I'm sorry, Nathan, what were you saying?
I think the other piece we haven't talked about, Matt referenced that the only thing, the plantar fascia is not the only thing under your foot. There's 4 different layers of muscles. And so another thing that I myself, and something that I have my patients start early, is working on the muscles that sit on the bottom of the foot, as well as some of the other muscles outside of the ankle that support the arch. So I'll have people work on what I call dome and spline. And so all of the muscles that sit just on the inside of your foot are called intrinsic muscles, because they start and end on the foot. And so doming is like trying to take the ball of your foot and pulling it towards your heel without curling your toes. And so that's a dome. And then a splay is just trying to spread all of your toes apart. And what those 2 exercises do is they activate a lot of those muscles that sit underneath the foot. And the reason you'd want to work on that is because they are dynamic supporters of the exact same thing that the plantar fascia is trying to do. And so if you are activating them and getting them ready, they can be an assistance to the plantar fascia if it's irritated. Yeah. In the same way, working on tibialis posterior, which is a muscle that comes down the inside of the ankle. And then you can looking at another muscle, peroneus longus, which comes around the outside but wraps underneath. These are muscles that also support the arch. And so getting them active, not like I don't have people do heavy weights, it's just repetitive kind of band work just to get those muscles active, can be a helpful way in the kind of early niggle phase of do you guys call them niggles? I call them niggles.
I've never addressed, I've heard you say that so many times. Like I've heard that phrase before and I haven't really addressed it, but no, not really.
I mean, but I know what you're referring to, and
yes, we know
that it doesn't weird me out.
Is that like an Midwest East Coast thing?
No,
I've heard that here.
I know people out here that say niggle.
Yeah, just when you first start to feel it, that's what we'll say. Then I have people start intrinsic footwork, as well as working on those other 2 stirrups, I like to call them. You know,
I call them stirrups as well.
And the mechanism behind this is this is why in PT we do this all the time for passive structures, right? The stronger, and we know this from the evidence, the stronger the muscles are in an area, the more pressure they're going to take off passive structures, and vice versa. The weaker they are, the more pressure and stress on those passive structures. So getting these active and strong is really important. There's also the challenges when you start having pain, it tends to inhibit muscles. So the first thing you want to do is keep those muscles on, because if you have an irritated tissue that is not being supported by muscle, you're actually going to get more stress on it. So it's a mechanism that's not quite the best for a lot of situations. So keep those muscles on.
Yeah. Awesome. One thing too, if you don't have access to bands or a PT immediately, you could do the domes, the planes. But one thing I like to do too is great toe depression. That's one way of activating the peroneus longus and creating a little bit of intrinsic support and activation to the region, as long as it's not too painful.
Describe great toe depression.
Yeah. So if you lay your foot flat on the ground, your big toe, you're just gonna, and only the big toe if you're able to, but you're gonna push that big toe into the ground. You technically don't need the ground, you could do it with your foot off the ground, but sometimes it's easier to have the feedback from the ground from a tactile standpoint, just to fire it a little bit easier. And you can just do it sitting, like you don't have to be standing and doing this. But just getting some gentle isometric activation can also relieve some tension as well.
Awesome.
Yeah.
Cool. So there's some quick tips. I think that if you've tried things like this, and nothing seems to be working, this is where it's worth going in and seeing an ortho-PT specialist to kind of screen out some other stuff and maybe have some other tips. There is also evidence for early use of things like heel cups and like soft orthotics early on, not long-term. Long-term, no difference is what the kind of research is bearing out at. But short-term for pain relief, if it's a little bit more acute and you want to be able to walk without pain, putting in like a gel heel cup or something just to cushion that can be helpful. And same with kind of like a taping. But the taping is usually done by rehab professionals. So
unless you know how to tape, but the tape, again, Nathan made a great point. Taping, an over-the-counter orthotic, you don't need to get fancy. The gel, these are things you can pick up at whatever local store, like supermarket, what have you, should usually have them in the health section. But remember that they are short-term. It's good for getting you out of pain, but it's not meant to be an ongoing intervention. If you are doing that, you are likely keeping yourself in a situation that may or may not be, leading to a chronic injury.
I think what happens mentally is they've been shown to help in the first 1 to 3 weeks. So
very good. Yeah.
What happens is you start to use this thing and then you think that's what made me better. And it was a piece of the puzzle, but you won't be dependent on it. And
right.
I think it is a really nice tool to use early on. And then kind of go from there.